So good afternoon to everyone. We are pleased to have here Laia Maynou from University of Barcelona. We are especially thankful for her, and we should be especially thankful to her to have come today because she's accepted our invitation in advance state of pregnancy. How much? 300 months? 8 months. So Laia holds a PhD from University of Girona, and she works in applied econometrics, especially in health, where she has an interesting record of publications. So we are looking forward to your presentation. So you have around 45 minutes and something like that,
okay.
And people can interrupt you.
Yeah, sure. Yeah, okay. First of all, thank you for inviting me. I'll be doing it standing. If I need to sit down, I'll sit down, but hopefully it should be okay. So thank you for the invitation. It's a pleasure to be here. I am based at the University of Barcelona. I've been many years in London at the LSE, where one of my co-authors is from now. So this is a joint work where I'm going to talk about joint work with Alistair Maguire, professor at the London School of Economics, and Victoria Serra. She works at the Department of Economics at City University in London. And this is a project that was funded by the Health Foundation, which is an organization that is in charge of health projects, and as you might know, in the UK, health economics is quite a popular and important topic. So what I'm going to talk about today, it won't be too clinical, so don't worry, it's not super health. It has a health component, but the idea is to talk about robots and to talk about robotic surgery. So applied to the English NHS, which is a public health system. So I'm going to talk about how the robotic surgery was implemented in England and how it has diffused over time, and what are the main efficiency gains and productivity gains of that type of surgery. Where do we place all this topic in the literature? So as you know, robots and automatization has been a subject that it's been studied by many economists, with the idea of seeing, are the robots going to replace employment? Are we losing employment because of including technology in our companies, in our factories? So that's something that it's been studied. And basically, what's the impact of that? Are we reducing employment? Are we reducing or increasing productivity because of that? What's happening with the workforce composition? There are several papers and recent papers looking at that, from Acemoglu, Grades and Mitchells, Koch. So all these people that are trying to understand what's happening with the implementation of robots in our economy. And what they mainly find is that it might be reducing employment and wages, but it's affecting mainly the lower skill part of the distribution. So it's not really affecting the high skill people. And through that, the gains in productivity and employment are seen basically from the high skill part. So these studies have been done more at the macro level. There is one, the Koch et al. 2021, which is done at the micro level, at the firm level, at basically workers level. And they really see that the lowest skilled ones are suffering from the implementation of these robots in the factories. But the net employment gains are there, and are there through productivity. So there's a productivity increase thanks to the robots in the factories. So basically, in line with this paper, what's being concluded, it's still a hot topic and people are still studying that, but what the literature concludes is that there's an improvement due to robotic implementation. There's an improvement in employment and productivity in general. Okay, so we might see that the lower part of the distribution, lower skilled individuals lose jobs, but the net effect is positive. So what do we do? In the healthcare sector, we've also introduced some robots, and the robotic part of that is robotic surgery. So now what we see is that, for example, in Barcelona, most of the big hospitals have a robot, and that robot is used in the surgery procedures. So I'm going to talk about today is how this robotic surgery has been diffused basically in England. We are trying to start some work in Barcelona too, but the data I have is England for the moment. So we want to see what has happened with that diffusion. And I'm going to focus on a particular type of intervention, which is the one that's been used the most with robotic surgery, which is prostatectomy. Prostatectomy is a type of treatment that's done for prostate cancer. And basically, it's one of the type of treatments that we've seen the robotic surgery the most. And not only in England, but also in Barcelona, and also in the US. It's true that in the US, we've seen a diffusion of robotic surgery even to many, many other things. So now they are doing knee replacements and hip replacements with robots, which we still don't know if it's really effective, but they are doing that. The one that we know that it really brings us some particular gains is in prostatectomy. So when we look at prostatectomy, which is the removal of the prostate when you have cancer, you can do it in 3 ways. The first one is an open procedure. So we open, it's a big incision with the risk of blood loss, etc. So that's the traditional one. Laparoscopic surgery, which is an improvement, and it's a minimally invasive technique where basically you do an incision, but the incision is much smaller, so it's like usually 3 small cuts, and that reduces a lot blood loss and complications. And I'm sure you've seen that in knees and in other things, but in prostate cancer we can also do that type of technology. And the new one that it's been there for a bit now, it's the robotic surgery. So we use that in prostatectomy with the idea that you need to imagine that the surgeon is still behind the robot, and it's the robot doing the incisions. So basically there's a kind of a joystick, and the surgeon is going to guide the robot on where to go. It's not the robot doing the surgery alone. The surgeon is always there. So we are not losing any workforce because of the robot. We have the surgeon, and the surgeon is going to be there. So far, I haven't seen any robot performing alone. So the idea is that with the robotic surgery, what the company that designed the robot says is that the surgeon can be very good with laparoscopic, but it can still be not super precise. While the robot is going to be very precise to the millimeter, and it's going to still even reduce more the complications that we could see from laparoscopy. So that's what they said. But no one has tested if that's correct. There's no real economic analysis in terms of cost effectiveness or more econometric analysis that has looked at that from an efficiency point of view. And that's what we're trying to do in this paper. So really trying to tell if all this money that has been invested in robotic surgery in England, which is a public system, remember, so basically it's the government paying for that, if it's effective or not. The robots, yes?
I'm just wondering if this robotic procedure, this new technology, if it has like learning by doing, if that would be a strong component or not, because that would change the way you look at the data, right?
Totally. So there's a learning curve. So we'll see from at the beginning, we'll see that the robotic surgery was used in patients that were younger and not very sick. Over time, because we have data from 2000 to 2019, we see that we perform this surgery to sicker and older patients. And that you can see also over time that they do better. So surgeons do better over time. So you need the training to use the robot, but by doing it, you learn. So let me introduce you to the Da Vinci robot. This is the main robot that we have in the market. And this started beginning of 2000s. And it was spread quite quick in the US and in England too. And when we started doing this analysis, we didn't really know if that was a big thing in England or not. We didn't know how many hospitals had a robot. So when we started looking at the data showed us that in all this period, 2000, 2018, 19, where we start seeing robots is 2006, we start seeing robots in 2006, there are 54 hospitals in England with a robot. 54 out of 173. So it's quite a big proportion of robots. In a particular intervention, which is prostatectomy, that at that point there was no paper telling you that that was better than laparoscopy. So, and you need to see that it's quite costly. So it's a big machine that it costs 1.7 million pounds, more or less, with a cost per year of 140,000 that for maintenance every year, and for every surgery, it's around 1,000 for disposals. So we are talking about a big medical device that it's expensive, and a lot of hospitals in England bought it without really knowing if that was better than laparoscopic. So that's the whole idea that moved us into that. In England,
excuse me, can you explain again why is it used on prostatectomy instead of other surgeries?
It's the easiest one because to basically use the robot, you need to have a clear view of where to go, and all the abdominal surgeries are easier to do than a knee or any other surgery. So abdominal surgeries are the ones that are being done with the robot, and in particular prostatectomy because it makes it quite easy to remove.
Mm-hmm.
So it's for location of what you need to do.
Right, it's the easiest.
It's the easiest. So in another paper we've looked at what other surgeries they did, and mostly the abdominal ones are the big ones. They are starting with more things now, but still very low volumes. So one thing on the robots that's happening now is that the patent for the Da Vinci robot is expiring. So end of 2019, 2020, that patent expired, and now there are many robots coming into the system. So it's not only the Da Vinci that's going to be there. We are working with a company in Cambridge that are releasing a new one. We know that Google with Johnson & Johnson is releasing a new robot. So all this this is a market for them, and basically they are basically saying that their robots perform better than the Da Vinci. They try to market that in a way saying that it might be better for the patients, but we still don't know if that's really the case. So, okay, so yeah. So let me put that into the literature, in the health econ literature. So the first part that we think we contribute is on the diffusion part. So if we bought robots from 2006 onwards, how has been this diffusion? How have we used that? Are we buying them and using it or not? So what we see in England is that there's been an increase from 5% to 88% of surgeries done with a robot over this time period. So there's a big increase, basically in a way saying that the newest standard way of treating prostatectomy is with the robot. So we don't use open very minimally, lap very minimally, we go to robots. And it's been diffused for other procedures, as I was saying. You can see that in bladder, in gynecological treatments, but mainly still the big one, the one that gives you more volumes, is prostatectomy. Maybe because it's difficult to do it, it still creates some complications, they are still learning, but you see that it's happening. In the US, even more. In the US, they've been trying it for many things. So I would say it's sometimes a bit risky, but because we don't really know the outcomes of it, but it's even more diffused than in England. And in the UK, we've seen that increase. In a previous paper that we looked at why we are adopting the robots. So what's happening in the NHS in England to really uptake this technology. And what we've seen is that what really drives this is having a big department of urology, so the workforce using it, and hospitals that are in a richer catchment area. So these two main factors were explaining us the reason of adoption. So these 54 hospitals. And there is a paper that it's been recently out in the US where they also look at the diffusion of robotic surgery, and basically they said that robotic cases increase in terms of patient admissions, and that's related to patients that were younger and healthier. And that's what we also see in the UK data set. At the beginning, we treat patients that are young and healthier, while over time we start to treat patients that are a bit more older and sicker.
Sorry.
Yeah.
Does it mean that it's a patient choice? So you can choose whether or not be treated by the robot?
In the US, yes, because it's a private
UK?
sector. In the UK, it's a public sector. In theory, it's the surgeon deciding what you are going to have.
But you can argue with that.
Yes, so you can argue, but basically the preference is based on the surgeon.
Okay.
And it might depend on some particular characteristics of the patients. So we might see someone that is super sick or someone that's very old, they might go for an open procedure. So they are still not really going with the robotic to people that are super, super sick. But what we see over time is that as they improve the technology and they improve the way they do it, they are trying to treat patients that are older and sicker, but not at the beginning. So it's a learning by doing.
So,
Go ahead.
so in the UK, the NHS is fully public.
Yes.
So for those surgeries, do people pay part of it, or it's fully
Nothing.
it's
It's
fully
free.
fully public?
Yes.
So I was just trying to understand what the last bullet point means, because if I understand that correctly, what it means is there's more cases treated when this new technology arrives. But I mean, I just wonder if this is supply or demand, right? Like, I mean, I don't know if that's saying that.
The US works a bit differently than what we are used to here. So private hospitals want to attract patients. We need to think as business. The
Exactly.
hospitals are business.
Exactly.
So they convince the patients that maybe the robot is a good way of getting the surgery, and what they attract is patients that maybe are a bit younger, because technology is, you are more used to technology than people that are older, that are maybe they're more they don't really want the technology. So
Yeah, or it could be patient expectations that,
Also,
you know,
yeah.
like, so I don't know if it's supply or demand.
in the US it's a bit more tricky.
Yeah, yeah.
Just, yeah.
Yeah, I don't know if we can talk about that later, but just to clarify, you said that there is, because substituting robotics for other production processes is because you reduce cost or you increase the quality of quantity of production. So in this case, you already rule out the reduction of cost,
So
because it's the same number of at least the highly skilled people behind the
in terms of workforce, there shouldn't be any change in terms of cost, because you still need the surgeon and you still need the nurses and the people that will be in the ward with you. But in terms of cost, this is more costly than the other two techniques.
Okay, but then you can increase production? I mean, you can have more surgeries?
Yes,
Okay, so
because
there is
usually
a-
the time is shorter and you can do more during in a particular day. But still, it's not that you can do 10 more. So you can do a bit more, but it's not a big increase. The days have the numbers, the hours that they have. But it's a bit shorter.
So, but in terms of productivity, there is an increase in productivity in terms of quantity of,
Yeah, I'm going to show you that, yeah.
and you have data on the quality?
Quality
I
will...
mean, say, this kind of surgery save more people than...
So I'm going to show you, we call it efficiency gains, which will be some hospital outcomes that I'm going to look at, which will be length of stay, how long you've been in hospital, if you've been readmitted in 30 days, if you had, how many visits you had after the surgery as a proxy for complications, and the number of days that you waited since you were, you said that you needed the surgery and you got the surgery. These will be the outcomes that I'm looking at, and it's hospital-based outcomes.
So then you could reduce the overall cost of a patient.
Exactly, by reducing the length of stay, by reducing readmissions or reducing the number of visits, and that's what I'm going to show you.
So that will explain why robots are better than this.
Exactly, but you'll see that it's a marginal gain. It's a still small, not very big. So I'm still not sure if robotic surgery is much better than what we had in laparoscopic, because it reduces some costs, but still you need to invest a lot.
And you consider the cost of life?
Let's look at what you do.
Yeah, we'll see now. Yeah, we'll
Okay.
see that. We'll see that.
No, it
The
was
same?
asking
Okay.
about time. So if you could do more surgeries in a day.
You could do a bit more,
Yeah,
a bit more.
Sorry, Laia, this is a naive question, I think, but since this is a state health system, so you say in your work you find
Ah, ya
the
pasa, pero venga, veo. Ya pasa,
Ni se ve, no se oye ni se ve.
so the main drivers of robotic adoption
desde aquí, sí. És que igual no ho han connectat, és que clar, jo li he dit que sí, però no té res de dir.
Es que no se
So since the main drivers, of robotic adoption is one is the location of the hospital within wealthier catchment areas. What do you mean by that?
So what we look at in England, what they have is per area they calculate an index of multiple deprivation, and you can see that in areas where there's less deprivation, they have a robot. They may have more better chances of getting a robot.
Okay.
So because it's a richer area, and maybe the hospital might think that it's a good way of doing it. It's still a public system, and the government is paying for that. But there's a decision of the hospital to buy the robot.
I see. It's more so that okay.
It might attract more people somehow. So this is on the diffusion part. So we've seen that over time. What about? I want to show you the map. So you get the red dots, if you see them from the back, the red dots are the ones that the hospitals that have a robot. So you get, basically what I want you to see here is that over time, there are more red dots spread across the country. So here what I'm already telling you is that this adoption has been like a staggered adoption. So we don't see that in just one moment of time, we see that over the full period. And if I had data now, we would still see that. The other contribution in the literature is more on the clinical part. As I was telling you, it seems there's no economic analysis that looks at the effectiveness of the robot in terms of efficiency gains. There's some clinical papers that looked at that very simple with descriptives, that what they say is that both laparoscopic and robotic techniques, which we call them minimally invasive, are better than open. But that's quite obvious because you don't do a big incision, and basically there are lower surgical margins, there's a decrease in blood loss and transfusions, less length of a stay, and improved outcomes in sexual and urinary functions when we treat this type of patients. We see that as in a descriptive analysis, but so we know that minimal invasive is going to be better than open, and we'll see that in the data. But what about robotic versus laparoscopic? Is that really giving us something else? And what the literature says is that if there's something, it's marginal. The problem is that the robot really is super costly. So if you were going to do a cost effectiveness analysis, which I'm not really doing a cost effectiveness, it's more econometric analysis here, you might not see the difference. So you might not really get to a point where it's better to invest on that based on the effectiveness. What in England, there is a body, is an agency that basically tells you how you should treat patients in terms of surgeries and if you need to use some medical devices or not, which is called NICE. And NICE set a guideline in 2014 and a new one in 2019 saying that basically the treatment for prostate cancer, which is the prostatectomy, is going to be cost effective if we treat more than 150 patients with a robot. So you at least need 150 operations per year to think that you are doing that you are better off in terms of cost effectiveness. From the data that I have, basically only 29 out of the 54 hospitals fulfill the guideline. So we don't get to that volumes. Not all the hospitals that have the robot get to that threshold, which already tells us that maybe they are not being very cost effective in order to basically surpass the costs.
So just understand, I mean, those 29 out of 53 may have adopted before these guidelines were set, right?
Yes, and then over time they increase volumes.
Yeah.
But if you look at the full picture, not everybody fulfills the threshold.
Right.
And it could be that we have some of them that they do meet very, very low volumes even over time.
Right.
But you are right, mostly you see that over time. So what I'm going to do in this paper, we have two main objectives. The first one is looking at efficiency gains, looking at some outcomes. As I said, we're going to look at length of stay, readmissions, number of visits to proxy for complications and waiting times. Just as a spoiler for the results, we see a significant reduction in length of stay in hospitals that use the robot. But I'm going to use that for the full sample, even if they do open, lap, and robotic. If you adopt the robot as a hospital, basically you see a reduction on in length of stay, and you see a reduction on the number of visits after the surgery. So it seems that there are some efficiency gains there. In terms of productivity, this is the second objective. Does the robot increase productivity in the hospitals? We do that at the hospital level, and what we see is that having a robot increases production by nearly 21 to 26%, depending on the method you use. It increases total factor productivity, and it increases labor productivity by 29%. So it seems that there is a positive impact, but when at the end I'm going to look at that versus the costs, it might not really satisfy all the costs that I'm going to have to put in. So the data I'm using is data from the NHS, from England, and it's a data set that it's administrative data that accounts for everybody in England that had a prostatectomy. So the good thing is that I have everybody. I have all the patients treated in the NHS. And we have information on the patient, age, gender, comorbidities, etc. I have 88,000 surgeries. That's the whole number of surgeries that have been performed. And if I show you some volumes, if it works, the gray line is the uptake of robotic in terms of volume. So you really see an increase of volumes over time, while open goes down and laparoscopic didn't go up as much and keeps it stable. If I show you the number of hospitals,
Sorry, I'm a bit confused by that graph.
No, I was looking for this one. By this one, yeah.
Yeah, no, because it seems like, I mean, it's not just the shares are shifting towards robotic surgeries.
They do more.
The overall volume is like doubling, or I mean, I don't know what the numbers are. But
There's a massive increase.
yeah, so
We
why?
treat more patients.
But the marginal guy must be different.
The marginal?
The marginal patient must be different from the average.
We are able to treat more patients
Yeah, and the new ones cannot be the same as the old ones.
as the old ones. Maybe before we weren't able to.
What I'm saying is the type of surgery that they're doing now with the robotic must be different from the one.
The surgery is the same, but we might not be treating the same type of patients.
No, the surgery big scheme is the same, but in the details is not the same. I mean, because
it's different
it's
patients.
a different guy with a different situation and so
But
on.
we are able to treat more also.
Yeah. No, that's fine. I'm just trying to understand.
To understand the
where we
future.
are. Yeah.
If I show you, the idea of this following graph is also adopters versus non-adopters. So obviously, if in the previous slide you see that basically it's robotic that is kicking in, basically what you're expecting is that hospitals that are going to adopt over the full period are going to do more volumes than the non-adopters. And just to show you a final thing on that is how many, so to justify the staggered approach that I'm going to use, is that you can see from 2006 the hospitals that adopted the robot. So in 2006 there were 6, 2007 2, 2008 7, etc. Going up to 54. Okay, so this is the staggered effect. So this is the data that I'm using. The analysis at for the efficiency outcomes will be at the patient level. So due to missing values, I'm going to use nearly 86,000 patients. I'm looking at several outcomes, with covariates being the typical covariates that you can use at the patient level, but we also include some hospital characteristics, because basically the adoption of the robot is a decision done at the hospital level, not only for the patient. So there's some characteristics that I'm going to control for. If it's a teaching hospital, the bed occupancy rate of the hospital, the number of sites that the hospital has, the number of doctors performing the surgery, and finally, a variable that a reviewer made us include in this paper. We are still in revision process, but they wanted to, in order to tackle selection, because basically it's the surgeon that is going to decide which surgery they are going to get, and it might be based on some characteristics of the patient. We create a variable that it's based on the preference of the surgeon. So in the data set I have a code for who is the surgeon intervening. So I can see the number of robotic open and lap surgeries that this surgeon did over time, or per year in that hospital. So we create a variable on the preference of the surgeon. And by that, we create a variable afterwards that it's telling us what's the proportion of surgeons doing more minimally invasive compared to open in the hospital. So this is in a way to control for this potential selection. What we see is that I said previously that over time patients are older and sicker and they come from more deprived areas.
So Laia, just to understand. So this patient case mix, that seems very important, no? Because
Yes.
of the idea I was saying that there's some kind of sorting, selection, however you want to call it. So how do these variables go to the fact that the type of patient may be different? I have no idea what this charts on comorbidity.
It's an index to control that tells you how many comorbidities you have, many chronic disease you have.
Okay.
So it's these variables basically are controlling its age based, how severe you are, what's your health status, and from which area you are coming from.
I suppose what I'm trying to figure out is there a way that you can control for the type of surgery that they are going to be trying to actually do? You know what I mean? Like it's something specific about the patient or the surgery that controls for the fact that these guys are different. That the combination of surgery patient is different from what it used to be.
The only thing you can do is adjust the model by that. No? So be able to include the variables in the model. So we control for the patient characteristics to see if that had any effect on the surgery, and then you can see the event study to see if over time there's been a change.
Yeah.
That's the way we try to control for it.
Let's see. Thanks.
And then the second part of the analysis will be at the hospital level, so we collapse the data at the hospital level, and from that we have an unbalanced panel of 173 hospitals. 89 of them are going to perform only open surgery, 30 perform open and laparoscopic, and 54 perform the three. So if you are a hospital that adopted the robot, you also do the other two techniques. So that's how it's established. Hospitals that are adopters, that are going to adopt the robot, if you look at the data, they have a higher proportion of foundation trust, which is something, it's a particular category in England. It's not super relevant, but they are teaching hospitals, that's relevant. They treat younger patients. They have more urologists, so they have more power from the urologist to basically ask for the robot. They have more nurses in urology, they have more support staff in urology, and they have higher labor productivity already. So these are a particular set of hospitals. So I'm going to try to control for that in the analysis too. For the production function analysis that we are going to do, I need the capital variable, which will be bed occupancy rate in urology. I need labor, so I'll have the number of consultants that perform the surgery. That's from the main data set, but I have another data set on all the consultants in urology. So not everybody is going to perform the surgery, but they have the full picture, the full number of nurses, and the full support staff. And I'm going to use intermediate inputs when I'm going to basically try to control for potential endogeneity, which will be the support staff. So I'll explain more on that when I get my turn. So I'm going to do the two parts, but I'm going to show you the results straight away. Okay? I'm explaining to you how I'm doing the models and showing to you the result on the efficiency and then on productivity. For the first one,
but your individuals are not the same over time.
excuse me?
Your individuals,
Yes.
your patients are not.
No, they're not the same. You are a one-off.
So how do you use fixed effects then?
It fixed effects at the hospital level because the variable adoption is at the hospital level. If you adopt.
Okay. If you adopt, okay.
It's a hospital. So that's a bit, I know it's more complicated than a normal analysis on two-way fixed effects. But in this case, you have the patient level because I want to look at the outcomes per patient, but the treatment variable is at the hospital level. Either you adopt or not.
Right.
So we start, the first part of the efficiency, we start with the two-way fixed effects. I don't think I need to convince you that that it has many criticisms now, so it's not the best way to go. But I'm going to show you the results anyway. to see the direction of the sign. So basically adoption is a variable that is going to be equal to 1 when the hospital adopts the robot in a particular time t. I control for some x variables, as I said before, time fixed effects and hospital fixed effects as a normal two-way fixed effects. We know from the literature that that doesn't hold anymore. Well, doesn't hold. It has some biases. Basically, when you treat units that enter at different points of time, and that entering at different points of time can have a particular effect. So there's an heterogeneous treatment effect. So we moved to these new estimators. We chose Callaway and Santana. There are others. It's still very new in the literature. We decided to use this one, but it could be an extra thing to do, like to apply the others to see what we get. But the assumptions are a bit different depending on the method. What the Callaway and Santana allows us to do is it relaxes this idea that the treatment needs to be homogeneous over time. So it allows me to think that an early adopter is different from a late adopter. And also it allows me to fulfill parallel trends. We know that's the main problem with div-in-div, because what it does is the propensity score matching from the covariates in the pre-treatment. So I'm going, what the average treatment on the treated is going to do is going to create a group time average treatment on the treated based on the covariates and basically comparing only the treated units with the control units with the weight. So I'm going to just compare the two that are the similar ones based on the covariates that I'm putting in the model. So it's quite, technically it's quite complex in the idea that it first does this propensity score matching and then calculates the average treatment effect per group, which when we say group means the different entrancy points in the adoption, and then it does the full ATT based on bootstrap and clustering at the hospital level. But this basically, the idea of that is similar to an event study, following the two-way fixed effects idea, but allowing this heterogeneous effect of the treatment. So this is, here I have more information, but this is basically what it does. You can use controls that are the never treated, which will be the hospitals that never adopted the robot, or you can have controls that are the never treated plus the not yet treated. So I can have hospitals that are not, that do not have the robot yet as controls first, and then they move to the treated because they are going to be different, and I'm going to move them to the treated group.
Laia, which one are you going to use? Not yet treated?
I'm using both.
Both?
Our idea is that the not yet treated are better because in my case,
exactly.
I can use more observations and it's really not affected before. So it's not a control that it's treated. It's going to be treated at the point, but not before.
Yeah.
Our preferred specification is the not yet treated plus never treated, but I also have the other one.
I have to say I'm not sure that the not yet treated version includes the never treated.
They do.
I think they're separate.
No, they put it together. You can specify to get the both.
Okay.
You can have the both controls together or just the never treated.
Okay.
So this is the method we are going to use. Let me show you. This is the two-way fixed effects, okay? I know it's a big table. The first panel, it's looking at the full data set. Basically, you do open, laparoscopic, or robotic. And the question is, if the hospital adopts a robot, is there any effect on these outcomes? You can see that it's the two-way fixed effects. It's going to be biased. We know that from the literature. So what you see, it seems there's a reduction in length of stay when I took the full sample, when I took the sample of open and robotic only, and when I took the sample of laparoscopic and robotic only. This is 0.5, 0.7 of a day. So it's quite small. So it's not even a day reduction. The other seem that they are not significant. But this is biased. It's not really comparing one thing to the other. It's not correct. This should be the correct one. This should be the Callaway and Santana. And this is the analysis. What it's telling us is that there seemed to be a reduction of nearly 1.7, 1.5 days in length of a stay in hospitals that adopt a robot. And there is a reduction in the number of visits after the surgery, in 1 year or in 2 years. Full sample, open and robotic only, the same idea. When I only look at laparoscopic and robotic, there is only a reduction in visits. that we don't see reduction in length of stay. To convince you that this is correctly done, let me show you the typical graphs of the Callaway and Santana. What will tell me if I'm fulfilling the parallel trends is that the blue bar should be not significant. And that's what we see in this graph. So I'm showing you only some of the significant coefficients. But the idea is that the blue bar is showing to me that there are parallel trends because there's no significance before. I might expect significance afterwards.
I'm a bit concerned that this staggered adoption may be driven by regional characteristics. I mean, I don't know how detailed geographic region, administrative regions would matter, but like, you know, London would be, rich areas in London would be the first ones to adopt, and then you move staggeredly towards.
I'm controlling for the deprivation of the area, which should be controlling for areas that are richer than others.
Deprivation meaning?
Deprivation is an index that is done in England. It's called Index of Multiple Deprivation that has several domains, and I'm taking the income one. So it's a rank of all the local authorities in England, and it's telling me which ones are richer or poorer in a ranking. So I control for that in the model.
But so the level of income doesn't matter in
No.
that ranking?
If everything is adjusting well, if the model adjusts well, that's controlled.
No, what I'm saying is if it's a ranking, then it means that the level of income...
No, the level of income doesn't matter, but I can see who are the ones that are higher in income level.
But seems like, you know, it's not between rank 3 and rank 4, then the gap could be very small, but between 4 and 5, the gap could be huge in income and so on anyway. Like it mutes the intensity.
Yeah, they are quite a small unit, so it's 15,000. Usually in every local authority there are 15,000 individuals. So it's quite disaggregated. But that's the maximum we can do with the data. Okay. So here I'm just trying to convince you that I'm fulfilling at least the properties to run these models. That the blue part it's fulfilling the parallel trends. You can see that this is something that happens with Callaway and Santana, is that at the extremes you might have bigger confidence intervals, and the reason is that you have, in that extreme part, you have less hospitals adopting. So the number of observations drop, so it's less precise. So that's the typical thing that happens with this analysis. But this happens with event studies too. As a robustness checks, we do many options. The never treated, for example, so we just run it on the never treated. Very similar. The magnitude of the coefficient is a bit smaller, but the same direction. Without covariates, so in a way, not trying to adjust for the parallel trends. The effects are a bit similar, but the magnitude is very small, closer to the two-way fixed effects. We only use, in the post-treatment, only robotic, very similar. We change this variable that I said on the proportion of surgeons that do more minimally invasive from 50% to 60 and 70%. Very similar, and as a falsification test, we apply that to another surgery, which is the percutaneous coronary intervention, which is a surgery on the heart cardiosurgery. So it shouldn't have anything to do with the adoption of the robot. So what we do is using that data on another intervention, looking at if the robot adopted the robot, did it have any effect on the length of stay of these people? And as you can see, it didn't. So it shows that it's only affecting the ones that really is performed with the robot. So this is for efficiency. How am I doing? Shall I rush a bit? Maybe no. So this is for the efficiency part, for the production function. Just to go quick, we are going to use production function. The idea is the output, number of surgeries. Input will be capital and labor, and we want to see the effect of this input on outputs. Very, very simple. The problem always with this type of analysis is that there is unobserved, the productivity is not observed, so there is endogeneity coming from the productivity part. So what we are doing is implementing some particular models that use structural equations to control for that. So the first one is Olean takes, that basically uses firm investment as a proxy for productivity, Levinson and Petrin that uses intermediate inputs as this productivity, and the one that we think that it's more appropriate in our case, even if we do both, even if we do the three, it's the Ackerberg, Caves and Fraser, which basically draws on capital inputs and intermediate inputs to basically then estimate the productivity and plug it in the Cobb-Douglas equation. So basically what we are doing is defining D, which is our proxy for an intermediate input, which will be support the stuff. The stuff that you have in the Word that is going to support you with the robot are the ones that we define them as intermediate input. And then you plug it in the output equation. So in a way we are trying to solve the endogeneity problem. If I show you some results, the idea is the first line of results. Basically we do plain or less, panel fixed effects, and then the same with the different methods. Our preferred strategy is number 6. And what you see is that hospitals, this is hospital level, hospitals that adopted the robot increased by nearly 21% the output. So there's a full increase, and that's what you see in the graphs already. But it seems that from the models, we really see this increase on 21%. We control for workforce, capital, and we also control for competition. What happened in a catchment area of 30 miles? This is the typical variable that we use in competition analysis, where you see whether how many hospitals you have in the catchment area of 30 miles that adopted the robot. So if you are a non-adopter, what's your production based on having more than one adopter around you? So you can see that it has, in all cases, a negative effect. So basically it's the adopter taking all your production. And it's a way to control for this competition. This is evolution, the productivity. So from the models, you can calculate the productivity. You can see that adopters do better in productivity, but not from the beginning. So they do better at the end. So there's a learning curve here, and it implies a higher productivity at the end of the period. This is the distribution of the productivity also. You can see that adopters in the final year do better than when they started with a robot, the red line. And for non-adopters, you don't see this big change. And finally, labor productivity. This is a more simple analysis. We are not claiming causality in this one. Even if we try to control for productivity coming from the previous analysis, our main regression here is total volume of the hospital divided by the number of urologists, and basically we look at the effect of adoption, competition, and the covariates, with the idea of seeing if having a robot not only incremented productivity, but also incremented labor productivity. Are the surgeon able to do more? And this is a plain descriptive. It seems that adopters already were doing more in terms of labor productivity. And this is the analysis. The first line is what matters here. If you adopt a robot in your hospital, you will do 8 more surgeries. As a surgeon, you do 8 more surgeries per year. So it seems that it's increasing labor productivity. And we control for productivity coming from the previous analysis. Even if we believe that this might not be perfect, it's a way of at least controlling for some potential endogeneity. So overall, to summarize the results, it seems that there are efficiency gains from using the robot. In this particular surgery, in prostatectomy, over time surgeons do better, and it seems that they improve some outcomes at the hospital level. It's true that we are not able to basically capture some more detailed outcomes like complications or blood loss or in the ward complications or outside. So it's not so detailed, the administrative data. So we have been trying to look at data that it's more granular on that, because that's what the Da Vinci company claims. It's not only about length of a stay, it's about complications. And our only way of capturing complication is how many visits you had after. So that's the only way we have. So it would be interesting to go more in detail. So it seems that length of stay decreases, outpatient visits decreases, and hospitals that adopt a robot have a higher number of surgeries and higher labor productivity. What we do very quick, I just want to show you, is that if all the surgeries that we got in 2019, we've had around 9,500 prostatectomies. If all of them were done with a robot, knowing that you reduce 1.7 days in the hospital and you reduce the number of outpatient visits, what I can tell you is that you might save around £5 million. Is that a lot? Well, not really. If basically you have to pay every year 150,000 just to maintain the robot in the hospital. That's the total number, so it's for all the hospitals. And you need to pay upfront nearly 2 million to get one robot. So it seems that there's an efficiency gain, but it's quite marginal compared to all the costs that the NHS needs to incur to maintain all the robots and to basically buy the robots. So it's a very simple analysis. It's not a cost effectiveness analysis. It's just basically giving you efficiency and giving you production function. But what we believe is that that's not really still justifying fully the use of the robot. So it seems as efficiency gains, it seems that the production increases, but paying for the robot, maintaining the robot, it's still very expensive. So it's not really surpassing the costs. And that's it. Thank you.
Any additional questions?
Very quick, because I think this is a dramatic increase in the number of patients. So then either before robots, people just die because they don't get surgery, or the average days to wait for surgery is shortened.
There's no effect
or
on
it's just
waiting.
a dramatic increase in the number of cancer. I mean, because that could change the type of patient. So it may influence the success rate or whatever. So that's something that you may want to consider. And so, I mean, so you see an increase in productivity that you can tell by just the
By the
raw
data,
because there is
Massive
more.
increase.
But in terms of efficiency, if you change your sample of patients, then you may confirm results. Something that worries you.
Yeah, I know what you mean. We try to adjust for everything we can, but I still agree that we are treating more patients now. So what happened? Are they doing better diagnosis? Are we, with the robot, are we able to treat more patients because there's shorter time in the ward? Or is it allowing us to basically treat younger patients that before we were only treating people with prostatectomy, with cancer at the end of life? So are we treating them now before because the robot allows us to do a better job? So that's what I think it's happening, but from the data cannot explain everything.
But you should add that to the benefit cost analysis.
Yes.
Because you are treating more
You are treating more patients.
Maybe avoiding future costs for the health system.
Exactly, and from this surgery, people don't die. And from prostate cancer, it's one with the highest survival. So it's not a type of cancer that people really end up dying, but maybe we are treating them beforehand now.
No, I was thinking because you have data on the age of
Yes.
patients, so you can change if mean is different, mean of age is different over time, because maybe really patients are more young.
They are young. We see that
they're younger, no?
Yeah, they are younger at the beginning, and then they get.
No, I mean treated patients. They
Yes.
are younger.
Yeah, I know what you mean. Yes.
Overall, not just by robots.
No, overall, yes. Yeah, that's the case.
Well, maybe it's what you said, that maybe before patients, like more old patients were treated, so they started treatment on
Younger
old,
ones.
and now more younger people that they see that okay, something is wrong, so maybe
Let's do the surgery straight away.
Mhm.
Yeah. The mean is, if you do it by years, the mean of the age is smaller. Yeah.
So with age you can control some houses difference
In the models, age is already there. I don't know how else like we could control for that.
No, because that I say that already, given that you have age inside the model.
To have in the explanation. Yeah, we can include that.
I mean, somehow the heterogeneity in the treatment effect by age could tackle this, right?
Yes, and
age is predetermined. It's not
exactly.
Well, I mean, for the patient it is, but for the choice of whether you want to.
For the cancer, it's not.
So yeah. Tricky.
In theory, the Callaway and Santana allows to compare same group, so basically the same type of patient based on the characteristics. So that's
But conditional on the covariates.
yes,
Yeah.
because it does a propensity score on all the covariates that you include. So in theory, that should capture. Maybe it's not perfect, but at least part of it. So I'm basically going to compare patients with the same that are similar in the treatment and in the control group in that particular year.
Yeah, I see what you mean.
Okay, she will be with us also in the 18 minutes here now. So if you want to keep the conversation, you will be with us.
Yeah.
So,
Thank you.
Thank you.
so thank you.